Okay, well, thank you very much to the organizers for inviting me to speak as part of the Cornea Society Symposium, and I thank the organizers from the Cornea Society for including me this morning. My charge this morning is to talk about systemic anti-acanthamoebal drugs with a special focus on miltefosine, probably the most recent addition to our armamentarium. Just in general, if you think about anti-acanthamoebal drugs, they act on acanthamoeba, which is a eukaryote. It has a very negatively charged surface, which is important in choosing medications for it. It has some similar components to human cells, fortunately and unfortunately, in the form of ergosterol, which is also found in fungal species, but is a relative of cholesterol, which is a component of human cells. They also have a unique component of beta-glucan, which is also uniquely found in fungal cells, but also in the inner cell wall membrane of acanthamoeba. So this is a chart of different antifungal areas of activity, and most of them do concentrate on either the cell wall or the cell membrane, and we'll go through why this is important as we go forward. In terms of drug targets and inhibitors in acanthamoeba, you can see that the vast majority of these are really grouped in a form that affect the cell membrane of acanthamoeba, and these include things like chlorhexidine, PHMB, amphotericin B, and some of the azoles, which target sterols. The phospholipid analogs, which I'll talk about, which is miltefosine, is one of those, also acts in this area, but also in other areas around the acanthamoeba, and that's probably some explanation of its effectiveness. So starting with direct membrane acting agents, there are polyenes like amphotericin, natamycin, biguanides, which we'll talk about. One thing to understand is that the components of a drop that you use actually do impact if based on the preservatives. And we showed in 2013 the benzalkonium chloride that's found in normal concentrations of antibiotics other than moxifloxacin are actually fairly effective against trophozoites. This was confirmed 2 years ago in a study out of Moorfields, which actually showed the benzalkonium chloride could be both trophicidal and cysticidal. In fact, they attributed the large portion of propamidine efficacy, or Broline, to the BAK and not the actual base drug. Speaking of the cationic biguanides, the ones that we think of are PHMB and chlorhexidine, but interestingly, alexidine, which was the component of contact lens solution that was implicated in the fusarium outbreak in early 2004, is actually a fairly effective anti-acanthamoebal drug. We don't know what the exact mechanism is, but it is a very small molecule and can penetrate and diffuse across the acanthamoeba cyst wall, which is of some benefit in killing more chronic infections. Interestingly, aminoglycosides probably also have some activity. It's fairly weak, mainly against trophozoites, and the one that's most commonly used is neomycin. If you look at some of the cell wall active antifungals, it's primarily polyene antibiotics and azole antifungals. And these are inhibitors of cell wall synthesis. They inhibit either ergosterol in the case of azoles, echinocandins work on the beta-glucan portion, and there's some other miscellaneous agents. We did have one patient that was treated with caspofungin systemically, which seemed to have some effect from it. But one of the things you can tell from the chemical structure is that it's quite large and may have some difficulty getting through the cyst wall. So this may be primarily active against trophozoites. The azoles are a group that have been tried in the past. Based on a paper by Schuster and Govinda Viswasara, or Vish, back in 2006, we were looking for additional options for acanthamoeba, and we found that voriconazole was probably the most promising agent. As you know, this is highly bioavailable. It does have some clinical activity against acanthamoeba, but there are mixed results in vitro testing. The first description of its topical adjunctive use was from Wilmer, where they felt that it did help with therapy. We published a case series of 3 eyes of 2 patients who had chronic culture-proven stromal keratitis, where in a challenge-re-challenge model, these patients were able to resolve their acanthamoeba keratitis with voriconazole alone and not as adjunctive therapy. So there is some efficacy against acanthamoeba. Other drugs include diamidines, the alkylphosphocholines, which I'll focus on later, and 5-flucytosine. The diamidines are probably the oldest drug that have been described for acanthamoeba, interferes with DNA synthesis and cell growth, It may also retard encystment. Really, it's primarily effective against trophozoites. It's really, and also minimally cysticidal. So we use this early on in the process, usually for the first month, but don't normally continue it because of its toxicity. And the components here are propamidine and hexamidines topically, but the only drug that's been used systemically has been pentamidine. This was described out of Iowa, where they used this as an adjunctive therapy prior to penetrating keratoplasty and felt that it was beneficial in reducing the number of recurrences, although there still were after their therapeutic keratoplasties. So concentrating on miltefosine, this is an anti-leishmaniasis drug with anti-acanthamoebal activity. It has fairly low toxicity, and it's been used widely in developing countries. It has a significant inhibitory effect on acanthamoeba with a cytal activity above 40 micrograms per ml. Interestingly, this was first developed both in Germany and in England simultaneously. In England as an anti-neoplastic agent, and it was in Germany as an immunomodulatory agent. So this actually is a very interesting drug, and it's an anti-neoplastic. It also has wide-ranging antibacterial, antifungal, antiprotozoal, and antiviral activity, and is also a suppressor of the immune system. So this is it's a very complex drug. You would expect to have a lot of side effects, but in practice, it's actually very, very well tolerated. This was part of the original paper where I found voriconazole. Miltefosine was always the more interesting of the two, but was not available here in the US. And was really shown to be cysticidal in a more rapid fashion than voriconazole. And we found that with voriconazole, we needed to treat patients anywhere between 3 to 7 months really for the drug to have full effect. So this is an alkylphosphocholine. It has an orphan designation in Europe, but it is now approved here in the US since December, I think, of 2015 for acanthamoeba keratitis and the year prior for leishmaniasis. It's still fairly expensive. It's dosed 50 milligrams BID or TID depending on weight, and there's a WHO recommendation and cutoff for weight where you would use one or the other. The big concern that most people have with this is in animal studies, it may cause fetal harm. So it's advised not to use during pregnancy or within 5 months following therapy, and I'll explain why in just a moment. It causes impaired fertility and is a teratogen. Really, for humans, the main side effects are vomiting or diarrhea. It may increase serum creatinine and also liver enzymes, but these are usually within the first week, and it's rare that it would ever actually cause any permanent damage, either from nephrotoxicity or hepatotoxicity. There have also been some reports of Stevens-Johnson, as there were with basically any drug, and some thrombocytopenia, but generally in widespread use around the world, even in areas with poor nutrition and poor follow-up, the number of descriptions of side effects are fairly far and few between. As far as the mechanism of action is concerned, we're not really sure what it is, but it appears to be an inhibitor of protein kinase B, which is an essential process in the intracellular signaling pathway. In leishmaniasis and in human tumor cells, it triggers apoptosis, and it's thought to interfere with the synthesis and integrity of cell membranes and intracellular signaling molecules. And this is a schematic on the right showing that it probably has multifactorial effect on the cell, including destabilizing the membranes of mitochondria, the cell wall, and also causing apoptosis, as I mentioned. Another advantage of the drug is that it's highly bioavailable, and the absorption is greater than 80%, and has a very long half-life, around 31 days. And the reason why the recommendation against having or attempting fertility is that the levels are detectable up to 5 months after therapy. So these are the early studies in the laboratory. On the left, you'll see these are several different alkylphosphocholine. So the one that was most effective was APC1, which is miltefosine, that you see in all of these curves is the lower curve, indicating the greatest kill rate. And in the right is graphs with different acanthamoeba strains, basically showing that it is concentration dependent and not so much dose dependent. And the bottom line there is really the 160 micrograms per milliliter concentration. This is a graph showing that miltefosine does have an extremely long half-life, and after a month of treatment, you can still find levels 5 months later, and this gives you an idea of the decay rate over time. They moved on to animal studies. These were well after the original description in 2006. They published in 2014 and 2012 in a Syrian hamster model. They were able to show the 160 micromolar concentration that was described earlier resulted in 85% cure, and that if you combine this with PHMB, it actually heightened the level of clearance of acanthamoeba. Bhupesh Bhaga at LV Prasad took that concentration and treated 5 patients. He felt that all of the patients failed primarily because they had an increase in the amount of inflammation. 1 patient ended up with an evisceration, 3 with therapeutic keratoplasty, and 1 was eventually lost to follow-up. You can describe that as a cure if you want. Our personal experience started in 2011, and that was an index case that you see at the top. This patient I'll describe later, but generally our results have been pretty good. We did have 1 patient who had enucleation, and that was because of epithelial downgrowth, not from persistence of the organism. We published earlier this year the multi-center experience with miltefosine garnered from 8 different centers around the US. Patients were diagnosed microbiologically in 12 and/or confocal microscopy. There was some crossover. Prior therapy, there were 14 of 15 that had biguanides prior, 9 had an azole of some kind, and 5 of them had recurrences after penetrating or therapeutic keratoplasty. You can see the average time from the time of diagnosis to treatment was 216 days. So these patients were all patients who were felt to be recalcitrant, with some on a shorter timeline. The results were that all patients at the end of the study were free of acanthamoeba. 3 were considered failures, 1 because they had epithelial downgrowth. Another one had recurrence after miltefosine, which resolved with topical medications, although miltefosine was probably still on board at the time they were using the topical medications. And then 1 patient had discontinued their second course after improving after their first course, having a recurrence several months later, but they discontinued because of elevated LFTs, eventually underwent a PKP and additional topical therapy, and was also disease-free. Importantly, all of these patients, about 3/4 of them experienced a large spike in inflammation around week 3 of treatment. And this took the form of either increased corneal infiltrate or increased anterior chamber coagulum. But these are modifiable with topical steroids in the vast majority of cases, and most patients continue therapy through that. 10 of the 15, interestingly, described a significant improvement in pain within a week or so of starting therapy, which was interesting, but we don't know what the mechanism is. There have been a number of other studies from the UK and from the US, which have described similar experiences. Dr. Amescu is going to be talking later, who authored the largest paper of this group. They had 6 patients, and they all had the symptom of inflammation with perforation. We were able to avoid that in all of our patients just by adding an immunomodulatory agent like topical corticosteroids to try to obviate that. And it seemed to be successful in allowing them to continue therapy. So in conclusion, miltefosine is a wide-ranging, anti-infective, anti-neoplastic immunomodulatory drug. The pharmacokinetics show a very high oral bioavailability with excellent tissue levels widely distributed throughout the body and a long half-life, which makes an ideal systemic medication for tissue-penetrating infections. The metabolism of this, basically it's broken down in individual cells into physiologic components. So there is no excretion from the liver or kidneys, and that's why the toxicity is relatively low. Main side effects are GI tolerability. There may be reproductive or teratogenic effects in animals, but hasn't been proven in humans. I think there's ample evidence now that in vitro and in vivo evidence that it has good anti-acanthamoebal activity when used systemically. And it's probably, in my opinion, the most effective of all the systemic medications that are currently described for acanthamoeba. The severe ocular inflammation can be modulated with adjunctive corticosteroid use at the time. Unchecked, it may lead to keratolysis and perforation. Interestingly, patients who are treated with this for leishmaniasis can also get an idiopathic inflammation of their eye, which may also cause some significant pain and morbidity. And this may be an idiosyncratic response of the body to miltefosine. And then finally, I wanted to invite you to my hometown and where I live currently in Chicago for the World Cornea Congress in 2022, immediately preceding the American Academy of Ophthalmology. And thank you very much for your attention.